To conclude the topic of impacted canines, I will present a very peculiar case that, however, is very useful to understand some important details of treatment of impacted canines. This is one of my biggest orthodontic failures, but that's what we learn from, and therefore I present it to you. This Anders was a very young patient, and you can see from the front that his midline is very much off to the left side. We can also see that he's got quite a lot of maxillary retrusion and he's got mandibular protrusion. At the moment of this examination he was rather young, around 13 years of age. And when you look at the occlusion, you can see that he's basically a developing class 3 patient. He was a good candidate for surgery already back then, but you can see that we have another problem. We have a huge midline deviation to the left side, with a space missing on the left side for about 13 millimeters, so nearly 2 feet of space missing. And one canine that is impacted very horizontal and high. We make a CBCT because from this picture we could see that there could be the possibility that the canine was incarcerated between the roots of the central and the lateral. And this is what we saw on the CBCT. The crown of the canine was actually incarcerated between the root on the central and the lateral and had already started to resorb quite relevantly the lateral. This was a very aggressive canine, and the obvious decision was to extract this lateral. And since we needed to correct also the midline and the patient was a candidate for lateral surgery, we decided to extract both upper lateral incisors. The incisor that was extracted is this one, and you can see actually on a picture the amount of root resorption that this canine had created. So after having extracted both laterals and having made space for the canine, we started to pull the canine away from the root of the central. So with a cantilever activated with a vertical, occlusally directed line of action. So a line of action activated downwards, with only downwards. Now see what happened. From the cantilever activated downwards, we have this, and look that the canine keeps going forward to the midline actually. More and more, up to when we start to correct it, but has already resorbed a part of the root of the central incisor. We've been discussing a lot why this happens. And actually the reason why this happens is this. Whenever you pull occlusally, you have to remember that you're pulling on an inclined plane. So a force directed occlusally can be decomposed in two forces, one of which is directed medially. It is very important in these cases, therefore, that the surgeon has to remove the whole bone around the crown of the canine, because remember, tooth movement happens with the mediation of the periodontal ligament. The crown has got no periodontal ligament. He has especially to remove as much as possible the bone of the palatal cortex under the crown of the canine. If he fails, the surgeon doesn't do so. When you start to pull down, the component that is in red in this image will tend to bring the canine still forward. And this has happened by making this canine resorb the root holes of the centrum. The patient moved away, actually, at half of way on the treatment. He moved to another town. But I was lucky because he moved to a friend of mine that was able to keep treating him. And he sent me the final picture after surgery, some years after. And you can see actually that still, you can see that there is some periodontal problem between the canine and the central. With the central that also will be lost. So the patient will need actually some bone augmentation and an implant. This was just to show you something that is very important to remember. The surgeon has to remove the whole bone around the crown, and you've got to be very careful when you've got canines that are showing a very aggressive behavior. So at the end of the presentations relative to impacted canines, what is important for you to remember? Number one, You should have a proper design of your cantilevers, with attention to the line of action, avoiding hindrance from the brackets and the premolars, and trying to have the side effect in the plane of space that you can control most. So, for example, like here, activating a cantilever by torsion instead on the second order. Do not underestimate anchorage requirements. If you activate a cantilever in the second order, what will happen? You will tend to intrude a mesial tip, the molar, and a transpalatal arch will not be enough to prevent this from happening, and can be also quite a radical side effect, so you have to be very careful in having adequate anchorage. If you've got canines that are impacted behind the apex of the central and the lateral incisor, you will have to start by pulling the crown away from the roots of the central and the lateral in order to avoid to hit the root of the lateral by bringing the canine vestibularly. You will have to be very careful in case you've got canines that are showing very aggressive behavior, and you will have to require the surgeon to remove the whole amount of bone around the crown of the canine. And finally, you will have to try to control torque with proper biomechanical system. With this one, I terminate my presentation about impacted canines, and I wish you all a very nice day.